What's that? Good morning, everyone, and we're back live here at the GuideWell Insights Lounge. We're at day one of the AHIP Institute and Expo. Hi, everyone. My name is Kate Warnock, and I am so delighted to have with me Dr. Angelo Volandes. Dr. Angelo, I should just call you Angelo. Everyone calls him Angelo. Welcome to the set.
Thank you, Kate. It's great to be here.
We're so happy to have you. So, Angelo, I know you're faculty with Harvard Medical School, but you're also the founder, or is it CEO and founder of ACP Decisions?
I'm co-founder of ACP Decisions along with my wife, would you believe it, Dr.
Fantastic.
Aretha Delight Davis.
Very good. And of course, you're also an author.
I am.
Yes, so very distinguished guest. We're so happy to have you here. So, Dr. Volandes, you are a champion of enabling patient decisions at the end of life. Before considering the patient benefits of this kind of care, can you kind of paint the landscape of what are the financial implications of end-of-life care as it's delivered today?
Absolutely. So when we look at end-of-life care, what are the facts? The facts are most Americans don't want to die in a healthcare setting, and yet most Americans are still dying in a healthcare setting. So for instance, if you're over the age of 65, 2/3 of Americans are going to end up dying in a healthcare setting, often with a good deal of pain and suffering, and sometimes with a tube shoved down their throat, even though we know most people don't want that. So what we try to do is empower patients and families to know what are the questions they need to ask their doctor, but also what are their options for medical care. And if you think about it, if we help patients empower them with the tools that they need, and in our instance, it's videos to help empower them, they can get the care that they want and that they deserve. And what we know is most people who have a serious illness don't want a lot of the expensive, costly things that we end up doing in our hospitals routinely on a daily basis. So what we're hoping, and what we've shown in our studies, as well as in the real world, is that when patients are empowered, they get the type of care that they want. So we're improving patient health, we're improving the health of the community, and we're actually being better stewards of our limited resources by not delivering unwanted care. Things that people simply don't want at the end of life, things that we know aren't helpful.
So Angelo, I know from doing research that, again, end-of-life care accounts for an incredible amount of those limited resources you were just mentioning. Do you have a dollar figure or something, some sort of statistic to let us know just how much does happen, how much is spent towards the end of life?
Yeah, so the number that's tossed around in the last year of life, especially for Medicare beneficiaries, is somewhere upwards of $100 billion. But we think it's far more than that, because what we're not taking account is all the things we're doing to people who have a serious illness who simply never wanted it. People who end up getting things because that's the way hospitals work. Look, the fact is, you end up getting things not because I'm asking you, but often because that's the sort of thing that we do as a healthcare system. And that's the problem with end-of-life care. Unless you say, hey, if I have a serious illness and there aren't things that are going to help me, unless you say stop, the machine keeps going.
Right.
And that's really what the problem is.
All right, let's unpack that response a little bit. We have two parties that really are impacted by this kind of care delivery. It's the patient and their family and their loved ones, and then it's the clinician. So take us back. You said that you create this video series. Tell us a typical use case for your videos. I want to know, how do people typically respond to it? And then a follow-up question, what happens when the caregiver isn't on the same page as the patient?
Right, so that's a wonderful question. First, let me start out by saying, as a clinician myself, I'm in the trenches every day. And what people fail to recognize is that I became a doctor because I got an A in organic chemistry, not because I'm a great communicator. And we have to recognize that most clinicians today were never trained on how to have this conversation. And so we're expecting them to do something that they were never trained. I was trained to put in central lines. I was trained to do all these procedures, things that I do, but we never stop and say, is this what's best for the patient? Is this what the patient wants? So let me give you a typical scenario. Suppose you have a patient who has a serious illness, let's say advanced cancer, less than a year prognosis, and the oncologist or the primary care physician feels a little bit uncomfortable about approaching what is inherently a tough conversation. Suppose they want to address things like CPR or things like hospice care. It's very difficult to have this conversation with patients. So what we have done is created short, easy to understand videos that explore the sort of big picture. So if you're a patient with advanced cancer, there are certain questions that I need to have a conversation with you about. What are your values? What's important to you? When you're not able to do the things that give you happiness, what are the sort of things you do or don't want physicians to do in the hospital or outside of the hospital? And ultimately, questions like, how does your religion play a role in this? Where do you want to spend whatever remaining time you have? And who should I be speaking to if you're not able to speak to me? Patients love our videos. The reason is because they're crafted by patients. So it's not just doctors, nurses, social workers, and chaplains who are creating these videos. We're a team of about 100 people at 10 academic medical centers. We actually spend a good deal of time hearing from patients who do have a serious illness, and they tell us, this works great, or no, that's really not the information that I need when I have this illness.
Okay.
So these are patients, for patients and by patients. And the question that you asked about family members, that's a really interesting question, because most of the time at the end of life, patients aren't able to make these decisions, and it's really the family member. And what we find is that if we have these conversations way early before that stressful moment comes, we find that patients and family members have the opportunity to discuss what's important to them, and we don't have that sort of disagreement or those really tough conversations. How many conversations have I had with daughters who are making decisions about mom with advanced Alzheimer's disease because they never had the opportunity to talk to mom before she had this illness? And I do blame clinicians. We have to do a better job of having these conversations earlier, of giving these tools to patients and family members so that we could honor and respect their choices.
Absolutely. So let's take it back to the clinician then, and the fact that you yourself, going through medical school, in organic chemistry, maybe not the best communicator, but again, as you said, medical education isn't necessarily focusing on empowering the clinicians with the right things to say, and I'm sure that these conversations are tough because they're taught to save and to heal, and a conversation like the ones that you need to have almost makes it sound like they're giving up on the patient, and that's certainly never a message that any clinician would want to have. So tell me, what can medical education do to better empower tomorrow's doctors to have these kinds of conversations?
Yeah, I think it's really important from the beginning to set the stage so that the students understand that it's not just, can you do the surgery? Can you do the high-tech procedure? Can you do a cardiac catheterization that we value as physicians? But we also value talking to our patients. Sometimes I have my residents and fellows who know the patient's lab values better than they do the patient in front of them. I think we have to go back to our roots, which is really the patient story. That's why I think most people get into healthcare. They enjoy talking to people. So what we have done is we've worked with some medical schools to get these videos in the curriculum. So for instance, one of our largest projects is in the state of Hawaii, where we've partnered with Hawaii Medical Service Association, that's the Blue Cross Blue Shield affiliate of Hawaii, and they've actually sponsored a program where everybody in the entire state, all facilities, hospitals, nursing homes, clinicians, all people, all 1.5 million residents of Hawaii have access to our videos, and they're being used in the professional schools. So now it's not just see one, do one, teach one, but a student can go home and say, let me see how a professional doctor does it. Let me see one, let me practice, and let me try to emulate that. So that's our hope, is to get this message early, and that the students recognize that this is just as important as during neurosurgery. Perhaps having the conversation is the most important procedure in medical care.
How about it? Well, one more question for you. So here we are, of course, at AHIP Institute, and we're a building full of payers. The conversation typically is only going to be held between, and rightly so, the patient and their clinician, their healthcare provider. Is there a role that a payer should play, and what would that be?
Yeah, I think there's a huge role that payers can play. Payers can help doctors and healthcare systems do the right thing. I think they can encourage, incentivize healthcare systems, hospitals, to encourage them to have this conversation early. I think we shouldn't wait for that ICU admission to have this conversation. I think payers can incentivize doctors to say, take a few moments out of the primary care visit, encourage patients to have this conversation. And you don't have to show a video right there and then. Perhaps you show it to them and you say, here's a link, go watch this video at home, and then the next time I see you, we can have a conversation. I think payers can also help the process when the people are in the hospital, because we don't spend enough time talking to our patients. We have to make sure there's personnel. This is not just a doctor-led issue. It could be nurses, social workers, trained lay people. I think payers have a huge role to play in this, and I think that the only way we're going to have success is if payers help us better understand this process.
Absolutely. Well, it's such an encouraging message and such a humane thing that you're doing. So I'm so grateful that you spent your time with us here, Angelo, in the Guidal Insights Lounge. My name is Kate Warnock. Thank you so much for joining us.
Thank you, Phil. I appreciate
We hope
it.
to have you back. We're going to be up soon with another interview. Please keep watching.